Well, good evening, or hello everyone, and welcome. Welcome to this Diabetes Language Matters Global Summit. I'm Greg Johnson, the Chief Executive of Diabetes Australia, and it's my pleasure to welcome you and introduce the event. Firstly, I'd like to acknowledge the First Nations people of Australia, the traditional custodians of the lands and waterways in which we live here in Australia, and pay our respects to the elders past, present and emerging. Sadly, I'd also like to acknowledge the passing late last week of one of Australia's great contributors to diabetes, Professor Trisha Dunning, who sadly died last week, and we're still coming to grips with the loss of Trisha, and she was a significant contributor to the Language Matters movement. We want to acknowledge Trisha in this event. I'll be leaving my role with Diabetes Australia next month after a bit more than 10 years as the National Chief Executive and leadership position in Australia. And I've been very pleased to have played a part, working, of course, with Renzo Shebelia, who will I'll hand over to shortly, who's made such a great contribution to this, and many others who are involved in this presentation and discussion. And we're very pleased to have started a discussion. It's 10 years since Diabetes Australia launched the first position statement about language and diabetes. And that was the start of a global conversation. Of course, we were responding, and many of us were, to discussions that were taking place in the diabetes community before that time. People with diabetes already knew just how powerful words and language can be when it comes to diabetes. Since then, there have been many statements and guidance documents launched around the world by diabetes organisations and groups across the world, in the United States, in the UK, India, France, Italy, Latin America, Canada, and others. The International Diabetes Federation launched a statement back in 2016, and indeed it was led by Trisha Dunning, who is a co-author on our original and new position statements. We now have a Language Matters movement globally, and it's common to see language being discussed at diabetes conferences around the world, and that's a great thing. Today, we're joined by some of the people with diabetes, some clinicians, researchers, and others who have been integral to getting the word out about why language is important. Renzo will be hosting a panel discussion so we can hear from the panel, and I'll let Renzo introduce the panel. I'd now like to hand over to Professor Jane Spate, who I've had the pleasure to work with since we were fortunate enough to recruit Jane here to Australia to lead the Australian Centre for Behavioural Research in Diabetes. And Jane's made a great contribution to this movement. I'll hand over to Jane now. Thank you.
Thanks, Greg. Thanks very much for convening this summit. I'm delighted to be here with you all. I'd also like to pay my respects to the traditional custodians of the lands on which we're meeting here in Australia. This Language Matters movement, as Greg pointed out, started 10 years ago with this position statement, and it really came about after a group of us were at a conference, and we heard some really quite disparaging remarks and comments, both from speakers at the conference and also from audience members contributing to the conversation. And we realised that this was not helpful, it was indeed harmful. And we thought, what could we do about this? And Greg quite rightly said, well, we can write a position statement and we can make this something for people to take notice of. It's not good enough that it's just in the research and that it's just a conversation that people with diabetes are having. We need to be clearer about why our language matters. So in 2011, we started this conversation, and as Greg has pointed out, it has indeed become an international movement. In 2014, the International Diabetes Federation, led by Professor Trisha Dunning, put forward its own language philosophy. In 2017, the Americans came on board, closely followed in 2018 by the UK. In 2019, we saw the first position statement on type 1 diabetes from India. And then just last year, we saw numerous position statements from Canada, France, another one from India on type 2 diabetes, and also from Latin America. And this year we've seen one from Italy. So this movement has really gained momentum in quite recent years, and we're really thrilled that all of these countries have come on board to make their voices known and to really add their weight to this movement and to say why it matters to them. And earlier this year, we produced a second version of our position statement here in Australia that was published in Diabetes Research and Clinical Practice in March. And today we're able to launch a brief version of that here with you today. And in this position statement, this revision of our position statement, a lot of what's in here is just reiterating what we already said 10 years ago, but we now have more evidence, and we've boosted the statement by providing some further guidance on how we can make our words show that we care and not show bias. And we've put some examples in of how to change our written language, and I'm just going to guide you through a little bit of that today. So the evidence shows that the diabetes language that we use has a harmful effect on how people feel, on how they behave, on how they think. And this has a very pervasive effect. It contributes to social stigma and discrimination. It alienates and isolates people affected by diabetes. And certainly the words that are used at diagnosis have been shown to have a lasting impact on people with diabetes. But it's not just on people with diabetes that this has an effect. The dark blue hexagons on this slide show you that the language that we use also affects clinicians' attitudes and the advice that they give to people with diabetes about treatment. It affects clinicians' burnout, and it also affects trainees being interested in specialising in diabetes. So these are just some of the gems of evidence that we've now accumulated over the years that shows really why language matters so much. And I very, very rarely use this word, but if I was to use this word, it wouldn't be to say that people with diabetes were failing their medications, as we often see in written works, but it would be to say that we as researchers and clinicians and as policymakers have failed people with diabetes with the language that we've been using. So our position statement now shows us that we can choose our words carefully to remove bias, to remove the blame, the irreverence, the authority and the stigma from our words. And we can use them to show that we care about people with diabetes. We can use them to show that we're curious about what's going on with them and their diabetes. We can use our words to be accurate in how we portray diabetes, to be respectful and to be empathic. And our position statement shows us how to use those words. And here's just one example of words that might be used in clinical records. We've got other examples in the position statement of how words are used in the media and also how words are used in research papers. But let's just take this one example as we have this brief opportunity today. So Jack has been a type 2 diabetic for 10 years. He's non-adherent. He's failing on oral anti-diabetic agents and with lifestyle modifications. His diabetes is uncontrolled. It's been getting worse over the past 12 months. His HbA1c is 9.4%. And we might say that this is quite a typical report that we might see in clinical records or in referral letters. But we can change these words. We can remove the bias. So straight away I'm crossing out all of the words in there that have some judgment and some labelling and some bias about them. And we can replace those words. We can show that we care. So here it is rewritten. Jack has had type 2 diabetes for 10 years. Sometimes he doesn't take his tablets because of their side effects. He finds it hard to maintain healthy habits at work. His HbA1c has increased over the past 12 months and it's now 9.4%. Now, importantly, what we've done there is removed those words that have bias and judgment in them, and we've replaced them with fact. And that's what I'm showing here in yellow. But even more importantly, we've actually created some space to show some curiosity about why Jack is having some problems with his diabetes and the way he's managing it. And so the highlighted green areas show that we can actually put in some more information here. And importantly, we're doing that with exactly the same number of words. So it's one of the key barriers that people cite is that it takes too many words, it takes too long to get our language right. But here we're showing that it can be done and with powerful effect. And Jane Dickinson, one of the authors of the American position statement, has said that excluding negative words could be a simple and inexpensive way to avoid negative outcomes, and I couldn't agree more with her on that issue. Over the past 10 years, we've seen that language is changing in the media, slowly but surely. This study from Bailey and McCrossan from the University of Western Sydney in 2016 compared the language in the media back in 2010, before we launched our position statement, with the language seen in 2014. And overwhelmingly, they saw that the language was moving away from the negative words that we were suggesting to avoid and towards the preferred language for diabetes, which is really great to see. But we do need more research. And a couple of years ago, Diabetes UK convened a workshop to identify the research that was needed to transform the mental health and well-being of people with diabetes. And in that workshop, clinicians, researchers, people with diabetes, people from Diabetes UK, all came together and put together a set of recommendations for the type of research that was needed. And improving the language was one of the key themes of those recommendations. And they said that we need more research on the impacts of language and also on what works to effect better outcomes. We really don't know enough about that yet. So even though we do need more research, it's really very powerful to change these words. We can start with ourselves. We just need to have the courage to call it out when we see it in other people, when we hear it, when we read it. Particularly in work that hasn't yet been published, do call it out and challenge yourself and challenge your colleagues to change those words, because that small change can make a really big difference, and our words really do have a lot of power. I'd like to finish, as Greg mentioned, by honouring Professor Trisha Dunning, a very, very valued colleague who we lost last week. Here is a quote that Trisha left us with. The language that we use is not consistent with personalised care. Be horse whisperers, not horse breakers. Thank you very much.
Thank you so much, Jane. And what a wonderful way to finish your presentation with, as always, very wise words from Trisha Dunning. I'm so thrilled. My name is Renzo Shebelia. I'm here from Diabetes Australia. I am so thrilled to be hosting this panel. I'm going to ask all the panelists if they wouldn't mind please turning on their cameras now. There were a lot of people that we would have loved to have invited to, talk language, but oh my goodness, did we manage to round up some of the most incredible voices in the world who have been speaking Diabetes Language Matters for 10 years and more. So please, I would like you to join me in welcoming Professor Partha Carr, who is the National Specialty Advisor in Diabetes at NHS England, Professor Tim Skinner, who is the Professor of Health Psychology at the University of Copenhagen and the Director of the University of Department of Rural Health at La Trobe University across Denmark and Melbourne and Victoria in Australia. Impressive. Steffi, who's the community manager, Steffi Hart, who is the community manager at DDoc. And I know that we have lots of our DDoc voices who are watching us, Steffi, cheering you on. And Nina Tush, who is the chief editor at I'm going to say it wrong. I'm going to throw it to you to actually tell me how I say it, Steffi. Sorry, Nina, how do I say the organisation?
Jebitupag.
There we go, because you said it with the accent properly, so I won't say that. But thank you all very, very much for joining me, and thanks to Greg and Jane for coming back too. Partha, because you're in the middle of my screen, I'm throwing to you first. And one of the things that you say is that when you're talking about language, you say, and I've written it down because I wanted to get it right. You say it's a reminder to be less judgmental about those whose lives you don't live. And I always appreciate when I see people acknowledging the lives of people with diabetes in that way. I know that you speak about language a lot to health professionals. And I'm wondering, how has that been received, and how do other health professionals acknowledge those words in particular? Do they understand why this is important? Oh, you're on mute. Sorry, I should have reminded everyone.
Yes.
There we go.
Yeah. So first of all, thank you for the invite. I think, as you all will know, it's an incredibly slow process to get people to come on board. And, I've worked with Tim before when he was in the UK. One of the fundamentals a problem that we have with clinicians, which I've learned over the course of time, is that if you take a step back and say, how much time have I spent in actually consulting as training? The answer is 0 to none. Okay, so I can tell you what's insulin and tech and stuff, and our nurse colleagues are far better at it. And you'll see that across the board. You'll see a lot of people coming back and saying, and you'll see a lot of clinicians or doctors, especially going, I think that really went well. And you'll come out and the person with diabetes going like, I don't think it went that well. And it's not very uncommon to see that. So I've learned that along the way. So when I say, that's what I've learned, I would say that, as I say, with the best will in the world, you will see somebody with diabetes 0.01% of their time, as one of your slides you've shown before. So in that minimal time you got them, the least you can do is be a little bit kind and polite. And I think probably the most revealing thing I had when we sort of got the Open University to do the research was one fundamental thing which came out when they asked a lot of people is that the opening question from doctors, and this is doctors I'm talking, not necessarily our nurse colleagues, was fundamentally one thing. How is your diabetes? Was question A when you walked in. It very rarely was how things. And so that was quite telling. So I think that sort of generates the view that I have, is that don't live their lives and without going on too much, you have had your fair share with the diet world and people telling you what you should and shouldn't eat. Same thing, Don't tell everybody to go and eat bacon and avocado when you don't know what they're struggling with to keep down 3 jobs and, family of kids and stuff like that. Same principle, really.
Absolutely. Thank you. And that's a great way to get us started. Nina, I'd really like to ask you a question about so you don't work for a diabetes organisation in terms of, Diabetes Australia, where I am. So how did the work in France start, and have the diabetes organisations taken this on board there?
Well, so everything started 1 year ago when I found out about the LanguageMatters movement, and I wanted to translate it and adapt it to the French context with Leonard, who is also a friend and the founder of a patient organization in France. And so it was very welcomed by the audience, our audience, and we talked about the document and the guidelines to the major organizations in France, and they obviously supported us, but unfortunately we lack the means, the financial and technical means to grow the movement bigger. So we had the support, but it didn't go very far with the time.
There's still time. It's still early.
It's been only 1 year for me.
Yeah, that's right. Now, before I get to Tim, because I've got a question for you, Tim, I just wanted to say to everybody watching, hello and thank you. Please ask questions. These work really well when they're interactive. We've got a really packed program, but if you would like to use the comments on Facebook, and if we can, we will certainly get to your questions. So if you've got anything that you're really, really wanting to ask, please do that now. Now, Tim, I was at a conference and there was somebody who was, I think, referring to people like me as non-compliant a lot, and you weren't happy with just saying, hey, this isn't great. You actually stormed the stage. Now, I appreciate and quite love your approach, but I want to know, how do people take it when you really are I really love this forthright and sort of, you don't give people much room to move. How is that received by others?
It depends on who you talk to. I think some people it feels like they just need someone to really actually confront them with that it's non-acceptable. Yeah. For me, I find there's sufficient position statements by several of our professional bodies. It's not just in diabetes, there's single perspectives about mental health and obesity. And people just haven't stopped to think about the harm that actually the language they use does. And I think sometimes it's just actually having someone who stands up and goes, hold on, you actually need to just think about first do no harm. Yeah. And actually, I feel like, and That's why Jane and I work really well together. She's the diplomat. I'm the bull in the china shop. And so it's like horses for course. We use the right person in the right context. So it's, but for me, I think sometimes people just need to go, no, this is not acceptable, and it's not something the reason I stormed the stage at that particular event was someone was saying, well, it's just the latest trendy thing, and it's like, no, this is not the latest trendy thing. This is having a negative impact on the lives of people with diabetes. And so I just wasn't prepared to let someone get away with dismissing something like it's political correctness. But not everyone's happy when I do it.
No, but that is a big thing about it's just political correctness. We're going to come back to that and have conversations about how we're changing and moving that needle, because I think at the beginning there were so many people just rolling their eyes and going, oh, this is just, it's so PC, but it is about more than that. We'll come back to that. But first, Steffi, I wanted to talk to you. Now, there isn't a German language position statement yet. Which surprises me sometimes, because there have been such incredible advocates, yourself certainly very much included in there, and the language used by the DDoC community is really very much about identifying why language is possible. And you've got wonderful advocates, of course, like Katharina Braun, who is actually encouraging people, and I know you're involved in this as well, talking to med students to talk about the language and why that's important. Do you think it's something that's coming? Is somebody going to write a statement, or is all the work that's being done by people with diabetes in the background, and people like Katharina also at a professional, in her professional capacity, is that making change?
Well, that was the perfect introduction, really. Well, yeah, it does seem like Germany is very late to the party. And speaking for myself, like I've been following this discussion ever since I basically found out I wasn't the only person on the planet with diabetes. So your blog was one of the first ones I found. And when I started my own blog in 2015, language was one of the first topics that I wrote about. And some of the comments on that were along the lines of, oh, you just started your blog and you've already run out of topics to write about. So that was the kind of mood in Germany, I feel like. And for a long time, it felt like all these advocates that you mentioned were kind of shouting into a void. And everyone we got into this conversation thought, well, yeah, but there are more important issues there. And I feel like it's now very late, but in the past few years, there have been some, for example, some blog posts that have gained traction and really caught the attention of people for the first time to have an honest and an actual conversation. And yeah, so you mentioned Katharina Braun of Charité, and we at DDoC, we firmly believe that language matters, and that's why we're currently in a process of setting up a patient think tank together with the Charité Clinic, very renowned clinic here in Germany, also based in Berlin. And one of the first issues that we want to tackle is this. So we're currently preparing some lectures and sessions for medical students. And also we're starting to work on a language position paper finally. So stay tuned. It's going to take us some time, but we hope to get as many people as possible on board.
Oh, good things take time. Greg, yeah. I'm glad you've come back, because I have a question, and this, let's solve problems of the world here. The media is a really big driver in terms of how people outside the diabetes world think about diabetes and what their beliefs are. And we frequently say diabetes has an image problem. It's fair game for B-grade comedians. It's fair game every, cooking show, and there are many that they're going to serve up diabetes on a plate. How do we change that? I know I was really pleased to see that Jane said it is changing, but we still see it. We still see it all the time. Why does diabetes have such an image problem? Oh, I think you're on mute, Greg. Sorry.
Sorry, silly me. So that's a big question. So firstly, just to unpack it a bit, I think it is changing. I agree with Jane. I think there's been some evidence in Australia from looking at published, the press and written stories about diabetes, that there's been, a noticeable and significant change in language. Certainly from our perspective, Diabetes Australia, in everything we do, and every time we go out with a story, every time we get asked, we provide the media, reporters, and everyone we can talk to, we provide them with the position statement. And whenever I talk to a journalist or a reporter, I always start off by talking about the language and making sure they've had a look at our position statement. And I've never had a journalist or a reporter argue about it or say that's, disagree. I think they're very accepting. I just don't think anyone's ever done it before. And they're not used to having organisations, health organisations, say language matters and language is important. And I think when that does happen, I think they're very receptive. Now that doesn't mean there'll be a permanent change, but everything's incremental. There is change, and we need to, like most big problems, it's not going to be solved by one thing. It's going to be solved by lots of things and incremental change over time. We have to keep at it. It needs to grow. We need to find stronger ways to talk about, to talk to more people and influence people. But I think there is positive. It's 10 years on really since this started in earnest, and I think there is change, and I feel positive about that.
Fantastic. So Jane, let's start with you, and then I'll ask a couple of the other panelists as well. But let's talk about this issue about it being, just political correctness, and it's just about, nothing more than that, and who really cares? There are bigger issues to deal with. And hey, there are a lot of really, really big issues in diabetes. No one, I think, for a minute is denying that. But I do wonder how we make people understand that this isn't just simply about words. It's about far more than just an individual word here and there. It's about those attitudes. How do you have those sorts of conversations?
Yeah, I think for me, the words are just so important. So we've seen research over so much time demonstrating that people with diabetes have impaired emotional well-being, that they have issues around depression, distress, and all of these things are really important. And people speak compassionately that we need to do more about that, but then they still use these words that are blaming them for the way their diabetes is going, or shaming them for not doing the right things with their diabetes, or talking about them in a way that makes them sound like a victim or sufferer. And all of these words are actually not congruent with that compassion that we talk about needing to support people better with their mental health and with everything that they do to manage their diabetes. So that's really one of the reasons why I was so intrigued by this when we started thinking about this a bit more, sort of more like 11 years ago now, really, was because the words that people were using were not congruent with the way people were saying that they felt about things. And I thought, well, that's just ridiculous. And we're never actually going to change this cycle of people having distress and depression and all of these things and not feeling supported with managing their diabetes if we don't actually change these words. And if you think about it, words reflect reality and they create reality. So, we can't think without words. The words are going on in our head and sometimes they come out of their mouths. And we have to think about which one comes first. Is it the words in our heads that are then coming out of our mouths, or is it the words that we're hearing that are then coming into our heads and messing around with how we think about things? So I think it's a really interesting challenge that we have, and I just can't think of anything actually that's more important. You said people say there's lots more important issues. I actually can't think of anything that's more important than getting how we think about diabetes right, so that what we say and what we do about diabetes is also right.
Thank you. Partha, the first 3 language statements or guidance documents that came out were from Australia and then the US and then the UK. And then you started working with a diabetes advocate from India, Jaz Sethi, and we saw a document to do with type 1 diabetes, and then later on one with type 2 diabetes in India. We would have loved to have had Jaz on here, but really we could have had a cast of thousands and it would have gone for 24 hours. And hey, I would have been happy doing that, but everybody would have been bored by the end of it and sick of me. But if I could just ask you a little bit about that, I'm wondering, were there different considerations when you were working on the statements in India, and what were they and how did you address the issues? Oh, you're on mute. We should be better.
So,
We're not.
I know.
Yeah.
So in India, we asked them, first of all, what would you like to do? We sort of said, right, diabetes as a pack. And one of the fundamental problems in India is the social structure or the huge amount of stigma that's associated with diabetes. So, for example, people not getting married, people being thrown out of their houses. We've got plenty of cases in villages where children were just disowned by their parents because they had type 1. Wow. And it's just ridiculous, right? And then you recently, as an example, you've had a very, very famous, man coming out and claiming he is curing type 1 diabetes. So you've had flocks of parents going there because they've said, right, we're changing your diet and giving you yoga or something and your diabetes is going away. So the advice that we had was actually create 2 separate, because it will also raise awareness, because type 1 diabetes, and just recently, I think the government has said finally they will give free insulin to people who have pediatric diabetes. They still haven't recognized that type 1 diabetes does exist in the adults. So we still, for them, it's just still pediatric diabetes. That's it.
Yeah.
So there was a fundamental problem there. So I think it was a 2-pronged attack on that. It was not just the language, it was also raising awareness of type 1. And then we had couple of clinicians who came forward, Dr. Latia and Dr. Chitra Selvam, who came forward and said, we would like to do some focus groups in type 2 specifically, and then created the type 2 document. So I think that was very much based on advice that we had from a lot of people on the ground, is don't go one. So that's why that split over there.
Right, yeah. And so just when you were talking about some of the issues that were perhaps in the, that you needed to think about, were they different to what you'd had to think about when you were developing the UK ones? You've mentioned some of those issues, but what in particular, what about the relationship between healthcare professionals and people with diabetes?
Oh, in India, it's incredibly hierarchical, right? Doctor says jump, you jump, right? That's it. And I think there is a massive problem. So you're starting to see some sectors change, but it is a very slow progress. And we have been to the whole gamut, which was mentioned about. I've been to meetings, people say, well, this is just politically correct stuff, isn't it? I mean, come on, we just need to give them the insulin and tweak it. Well, why am I going to spend time doing all this? And it's quite good to see. Last weekend, we had a meeting with the Type 1 Diabetes Collaborative over there, whereby there seemed to be a bit more acceptance that actually, and we probably need to sort of change our languages, so how we're interacting with people. It's taken a long time, but we managed to get a few good local champions there. And I think it goes back to the point which I try and make, is that if we want to change the dial, so some of you may know I've taken on a role about equality in the Beyond Diabetes in the NHS. And one thing I've learned is, for example, I always say, the issue of sexism, let's say, it's not just the role of women to go and solve it, right? You have got to have allies by your side to also be like, that's not acceptable. Racism is no different. And I think Language Matters with Diabetes needs that, whereby you will never get the nuance because you don't live with diabetes, but you need professionals to go and say to your colleague, that's very powerful for a colleague to turn around and go like, I don't think that's right. Yeah. So Tim mentions about the, going up to the stage and stuff. Yes, it has an impact because you have a colleague saying, I don't think this is right.
Yeah.
And I think that's why I give the analogy of racism and sexism. So in my career, yes, I've faced racism, but I've also faced a lot of people who have not had a bone of racism in them, right? And the reason for that is that because they will always stand up and go like in a meeting, go like, no, that's not banter. That's not acceptable. Yeah. And you need that in the whole community, I think, as well.
Oh, I think when we have allies, I mean, it's true, we are stronger when we're all together, but having allies and having health professionals call it out, I think it just adds so much. So, yeah. Now, Nina, I'm wondering about conversations that you've had with other people with diabetes. We've spoken a little bit about that, relationship with health professionals and touched on the media, but what do you hear from other people with diabetes? I know that because there's no one size fits all for any aspect of diabetes, some people couldn't care less about this, but other people are really, it's really important to them. What are you hearing and what are you seeing and what are the sorts of things that people are finding work when they're trying to have these conversations?
Well, the first thing is that I think when we talk about this Language Matters movement, I realized that many people had the same trouble as me when they tried to talk with their doctors. You were talking about the hierarchy, and that's still going on today. But the main thing that came out is how they met diabetes for the first time. when the diagnosis came, you know, and most of the time it's a very violent experience because often nurses do not know how to present the disease at first. So they just come and say, hey, here is the needle and you have to do it 4 times a day and it's for the rest of your life. But there are ways of presenting things. So I was surprised by how diagnosis is a very important moment in your life as a person with diabetes. And yeah, I think that's something we need to, the nurses and doctors have to learn how to present the disease for the first time. It's like a date, you know, when dating someone for the first time, it has to be a great experience. Of course, it's diabetes, it cannot be great, but you have to make it greater.
Yep, I love that. Now, Tim, I'm sure, well, I was going to say, I'm sure that you saw our National Diabetes Week campaign on stigma this year, but I shouldn't assume. I'm hoping that you saw our National Diabetes Week campaign on stigma this year. We had a short video, or a couple of videos, but one of them, when we went out to people with diabetes and we were, you know, asking what sort of things are really stigmatizing, and one of the points was that for a lot of people, unfortunately, it is healthcare professionals that are, you know, the biggest driver of stigma. And we finished off one of our videos was a man sitting in a clinic appointment and the doctor saying, well, you should have taken better care of yourself. We know that diabetes health professionals are experts in the work that they do, but they're not living with diabetes. How do we bridge that gap so that they have a better understanding of why their language and using terms like, you know, you brought it on yourself, that blaming and shaming, how do we get them to understand just how impactful that can be? You'll need to turn on your microphone, please, Tim.
We need to turn off mute. It's the standard line of our lives at the moment. Look, I just don't think there's one approach. I think we have to take a multi-pronged approach. One is we have to consistently keep presenting the evidence, you know, and one of the things that I think is really amazing is like first year undergraduate psychology, we talked about the priming effects, really simple things that you get someone to do, or you use some language with someone, simple ones are some things about being active or not active, and then you'll go and ask them to do another activity, go up a floor, and they'll walk up the stairs and go up in the lift. How you talk to them affects that decision that they take. Now, it's first year psychology, and yet, you know, we're not getting that message around that this language actually impacts on our behaviours. So we have to actually keep demonstrating and kind of drawing people back to that evidence base. I think we also need to keep going back and actually start embedding this in the undergraduate training of students and actually engaging them with some meaningful learning experiences in that place. So we've been doing stuff here where we actually get the students to go out and talk to people about their condition and the things that make it harder or not for them to experience and live with that condition. And they come back and they're always talking about the language that people have used and the attitudes of healthcare professionals and the media. And look, we also have to talk about the mass media. I have to say, I've got my wife's in the background watching Michael Mosley on television doing his thing about the diet in Australia. And I nearly turned it off because the language is so full of stuff that's judgmental, blaming, because I think one of the realities that I often talk about is we use this language in the healthcare professionals about it's like people of failure and it's a failure of willpower and motivation and desire. Actually, when you do the analysis, I was really introduced to this by a dietitian up at Newcastle when we were developing the Desmond program, who just talks about, you know, those little butter packs that you get when you go to a hotel and you've got to try and get that across your whole slice of bread and it won't even do like a corner of it. So, you know, they were saying that actually you only need to consume one of those more than you need a day, every day, to put on 1.7 kilograms a year. And so, you know, when you start thinking about that and you start thinking about the fact that you make about 120 food or drink related decisions a day, you know, not getting a good outcome is the failure of one decision per day. That's not a failure of self-control, motivation. And that's why it's so hard, is it is only one decision out of 120 per day that you might make in the wrong direction. And that can make it really hard for, you know, people to lose weight or gain weight. But we've sold this story. It's about big things we need to do and big changes, and actually for long-term sustained change, it's the challenge of small decisions, and that's why it's so hard. But the language is a language of blame and big decisions. So we really got to get across to help people understand kind of those issues in ways that are meaningful. My other big beef, Jane will tell you, is literacy of the stuff that we say. You know, there's the words, but there's also the literacy. And I'm constantly amazed how we still see like 80% of the material. This is a gross summary, but like 80% of the online resources that we see for people with diabetes are not readable by 80% of the population. You know? And there's no, in this day and age, when you can actually screen check, you know, import a document into Word, get a literacy level on that document within 30 seconds, there is no excuse for this. And yet it's still what we see time and time and time again. Our information resources are not designed to be accessible by the people that we're actually wanting to inform. So language isn't just about the words, it's also like the literacy levels that we talk about. And I think we also need to engage with that, because we're just disempowering people by not talking to them in languages they can understand.
Yeah, thank you. Steffi, I think one of the areas where we see a lot of that judgment and the words used around it really are just so judgmental is around diabetes-related complications. I know that for me, the day I was diagnosed, it was 23 years ago, I can still remember the way the endocrinologist presented diabetes-related complications. It was inevitable that they were going to happen, and when they did, it was my fault. Is that something that you think we really need to tackle, and is that an area that is particularly troublesome, I guess, for people living with diabetes?
Definitely. I think it's really interesting that most of us who live with diabetes still remember those conversations, and the words that the healthcare provider chooses on that day, they're ingrained into our brains and memories, and they have a really long-lasting effect. And I think it's interesting, you said that it's inevitable that they happen. When they were presented to me, they were presented as a threat that I had to avoid by all means. So that was my one job, basically. And they suggested that if I really, really tried, I could do it. And for me, that didn't work out. So I was diagnosed with complications 2 years ago, and it was a really interesting experience to be in that kind of limbo that everyone had talked about as a point in a future, like an end point somewhere along the line, maybe, but hopefully you can avoid that. But it happened very, very early for me. And I mean, hopefully at the end of my life, I can say that I lived the majority of my life with diabetes and with diabetes related complications. And so for me, one thing is to talk about how realistic it actually is to avoid complications. I think here again, language matters so much. So we often talk about avoiding, preventing, which suggests that we can actually have a fail-safe way. If like we have perfect blood sugars all the time, we can avoid them. I think that's not really true, because although an ideal A1C and time in range, they do have a level of protection, you still can develop complications, even if you're the perfect diabetic, as people like to portray it. So I think a level of realism there should be granted, and also, watching the language that we use. So minimizing risk, I think, is a much better way to put it. And that really clearly shows that there is still risk there. So I would love to see the whole narrative shifted away from this scary looming endpoint that we try to avoid, and more talk about what happens after, what happens if you do have complications, because life does go on, and there are people living in this world. It's not just something scary to hold over people, but it's a reality for so many of us. And actually looking around, all those like most of my friends with diabetes do already have complications, and they are around my age. So I think it's really time to shift that narrative to a level of realism. And I think that realism can also empower people to really know what they're up against, basically, know what they can do to minimize the risk, but also help them reduce the fear and just make them feel ready for if and when that day comes.
Yeah. Greg, as someone who has really championed that lived experience and having the voice of people with diabetes, front and center, and I know I've certainly been very grateful for that in the very long time, 19 years that we've worked together. How important is it that we hear from people with diabetes, that we hear about just how language can negatively or positively impact on people? Do you think that that's key here, as well as, you know, having these statements and hearing from researchers and hearing from clinicians? We need to, where is that voice of the lived experience? How important is that?
I think it's incredibly important, and it is growing, but you know, it's part of this. I think it's part of this movement here. I mean, here in Australia, I think the lived experience, you know, the language of that is changing, and a lot more, not just in diabetes, but in other spaces. We're seeing health spaces. We're seeing people use that language and acknowledge that lived experience is a really important thing, and hearing of people's lived experience. I think, again, it's a matter of the power of getting this message across about language matters and what it means to people is most powerful when it comes from a person with diabetes telling their story about what's happened to them. And every time, I'm still, you know, I've been doing this for a long time, and every time I hear directly from a news story from a person with diabetes, I'm still usually surprised at how significant the impact is on the person, and that is powerful. What I think we need to do is use all of these technologies and, you know, digital media and social media to get those stories out more and more, and have people, you know, I've often used the analogy about cancer, that people who've had cancer and a lived experience of cancer here in Australia and around the world, I'm very happy to talk about lived experience now. They don't get stigmatized, they don't get blamed or shamed, and it's a really accepted social norm. It needs to be like that with diabetes, and people need to be able to talk about their lived experience without the risk that they're going to be blamed and shamed. And organisations, diabetes organisations, need to take that on as a challenge in their strategic plans and commit to it. Just, you know, you can't seriously say as a diabetes organisation that you're working to support people with diabetes and reduce the impact of diabetes on people and individuals if you're not addressing the language that's used, the environment they live in and operate that's doing harm to them.
Yeah, absolutely. Jane, we've got a question for you, and it is, how do we show those that reckon people should just be more resilient rather than worry about language, the language used? How do we show people that building more resilience isn't necessarily the best solution?
Yeah, really good question. Look, of course, resilience is an important issue, but I think it gets far more airtime than it really deserves. I think, you know, that's like, you know, saying, well, Partha was talking about racism and sexism earlier. So it's like saying to a woman, you should just be more resilient about, you know, the sexism in society. You know, it's just not appropriate. We need to stand up and we need to say this actually isn't acceptable, as Partha was saying earlier, and make sure that people feel supported in everything that they're doing to manage their diabetes, whatever choice they're making or whatever choice they're not making. Some people don't always have choices, and I think that's a really important aspect of this as well, is that often we give credit for people having far more choice than they've actually got in managing their diabetes, through maybe affordability issues of not being able to access certain treatments or technologies, or food choices, or not food choices, as the case may be. So I think it's really important that we don't just put all of this on the shoulders of the person living with the condition to say, you know, it's your fault and you just need to toughen up, you know, and you just need to do better with your diabetes. And of course, people should be able to talk to you the way they want to, because actually it's all your own fault anyway. It's just not appropriate, and it's just unacceptable. And I think we just need to make a stand on it.
Yeah, thanks. Yes, Nina.
Something I learned with Language Matters is not to be silent. I've been silent for many years, and I didn't say anything when a situation or a conversation about my diabetes beat me up. But so with Language Matters, I realized that it's not because I'm a patient that I have to be passive. So that's also, that was my experience with.
Yeah.
language
And
matters.
Steffi, are you agreeing?
I absolutely agree. And I think we've talked a lot about the language that we use and the attitude that it shows, attitude of society and attitude of healthcare providers. But I think we also have to recognize that it changes our own attitude. The way people see diabetes changes how we feel about our own diabetes and our diabetes management. And I just on Instagram yesterday, I did a little like mental health check-in, asking some questions to get people thinking. And I asked the question, did you remember or did you try your best not to shame yourself for your own diabetes management? And not everybody said yes. So I think it was a valuable reminder for a lot of people, and also really showed me, wow, like there are so many people of us out there who really think so badly about themselves, even though they do try their best, and that looks different every day. But this theme of shaming and blaming, that also not only harms us from the outside, but it harms us like deeply within. So when we're talking about complications or just our daily diabetes management, all that shame and blame that's put on us, we internalize that. So that's another reason why we really need to fight for language here.
I think sometimes we're our harshest critics. I mean, that's, you know, we see that time and time again. Partha, when the UK launched your position statement, you broke new ground because the ones previously, one in Australia had been Diabetes Australia. In the US, it was ADA and AADE, who I can't remember what they've changed their names to, ADCES, I think. But yours was NHSE. So that was different. It was the NHS that actually adopted this. And what was the thinking behind that? I know that, of course, Diabetes UK also, you know, there were people working on it from Diabetes UK as well, but this was different. And I'm wondering, you know, what was the thinking behind that?
So the way I do my national role, I'll be very honest. I mean, I think if you look at some of the projects that I pick and run with, they're very much based on, a lot of it will be based on feedback that I'll pick up from a lot of people. And one thing I've realized very quickly is that diabetes charities, diabetes organizations will battle, and they battle a lot. They do their work, but you need somebody, for want of a better word, probably sometimes an insider person who will champion that from inside, because we will sit in meetings where, in spite of all the lovely words and PowerPoints about patients being at the center, there is not a single patient, right?
Yes.
There's not anybody living with diabetes. You're sitting there going like, how do you know? And the number of times I've had this discussion, for example, about Libra or CGM in pregnancy, and then somebody going like, well, I don't think this child needs a continuous glucose monitor. And I go like, do you have type 1? And they go like, no. Do you look after anybody with type 1? No. Well, how do you know then? And it's quite fascinating to see that whole, it's not just diabetes, it's everybody, right? Everywhere that happens. And that's fine if you're honest about it, that we don't think patients can make the call. And we're going to make the call for you, but we're not. We just go around and say, you know, we're all together. And so we have, in the past, I think it's been quite common to have Diabetes UK sit outside the camp, make their points, and you go like, that's very good, lovely document, thank you. But what we have done now is we have made Diabetes UK part of our board. Right. And I think that's really powerful, because then when we go across to, let's say, make the pitch for money, we go like, hey, listen, we are the ones, and I think that support. So Language Matters is the same thing. So I think we're doing it, but at the same time, with very clear support done by Ann Cooper and Bob Swindles and all those other people. You go like, we have just facilitated this. We haven't written. So I think having that stamp works. And as Tim will tell you, that blue and white stamp does count when you sort of into people who will go like, oh, yeah, it's a charity, and you can shelve it. Going like, I've got other priorities. But I think when it has that blue and white mark on it, the way the the way the British people look at the NHS is like a religion sometimes, it does have an impact. So I think that's the sort of tack that we have gone for. And we're doing the same at the present moment with closed loops. We're doing it the other way around. So we want that sort of philosophy to go through. Because otherwise, I don't think you can change outcomes.
Yeah, thank you. Tim, what's it going to take for clinicians who think that this is just political correctness gone mad to understand how important it is? Is it going to be really understanding what the health impacts are? You know, when we hear people say, I'm paralysed when I walk out of a health professional appointment because I'm in tears. Every time I walk out of my quarterly appointment, all I do is cry. I hear that from people. That's been their experience for years and years and years of living with diabetes. And then they go back in 3 months' time and they have exactly the same experience. What is it going to take to get the message through?
Oh, look, I don't know. I know what I'd like to try. And I've wanted to have the Rate My Doctor website. We get, there's been some political issues about some people who've tried doing that. But, I think, when does the medic get an opportunity to respond? It's like, I don't care. If you've had a negative experience, you've had a negative experience, end of story. We're used to doing this in so many other contexts now, whether it's Airbnb, eBay, where we're engaged in giving feedback on our consumer exchanges. I feel like we just need to be starting to have that clear and One of the things we know in healthcare professional land, one of the things that's been shown to consistently change prescribing behaviours, health professional actions, is where there's a reportable feedback on what people are doing. Normally that's done, anonymously, these GPs and provided data, and there's, lots of quality evidence data around. It's a really effective way for changing behaviour in healthcare practice. Normally it's that work is done in the context of behaviours like overprescribing antibiotics and different things like this, and quality outcome markers. But there's no reason why we cannot do that on people feeling how they felt when they walked out. And, there is really strong evidence. I think it was Moira Stewart from Canada published a paper as long ago, I think it was 1986, that showed the single biggest predictor of whether someone's health was better 6 months after a consultation or not was whether they felt listened to, attended to, and responded to in an appropriate way. And that's been replicated so many best times. It's one of the best predictors of outcomes of care. And yet we don't have that in any of our indices for quality assurance, quality markers in healthcare. And it's one of the most simple measures to get, a lot easier than a lot of the other stuff they use. So for me, until we can start engaging in some kind of process like that, all we can do is keep advocating, keep putting the research evidence out, keep focusing on trying to change. And I was just having a conversation with my wife today about this, like we can train the new clinicians and the new students, but they go out, they go back into the hospital, the health service, and then they're socialized back into the current way of doing it. It's really tough to come in as the student and go, hey guys, no, I know you've been doing this for 50 years, but this is not the right way to say that. You can't expect students to do that. So I think it's a really tough gig to go that way. Yeah. So until we get some kind of system of accountability and reporting in there, and if anybody's out there and wants to kind of set up Rate My Diabetes Doctor or diabetes care professional, then, I'm thinking it's something we need to engage with and think about that as a quality marker and making that kind of information available more widely. Because I have to say, not all health professionals are like this. I worked with some amazing healthcare professionals. But I would also say my one bit from the studies that we've done when we've looked at consultations, recorded them and done analysis, the most consistent finding we have is the nurses, the dietitians, the medics who are most critical of their practice are the ones that patients rate the most highly in terms of being listened to. Those people that are critical of themselves and their practice are the ones that in every single study they get rated by their patients as being the most supportive, the most encouraging, the most reflective. And I think that's one of the things that I've heard is, and I've come across that multiple times.
I was actually going to say that. I mean, I would only have an absolute glowing report of I named my kid after my endocrinologist. That sort of tells you just, yeah, I know, right? That just tells you how incredibly kind and caring and lovely she is. Greg, I think I may have said the last question was Tim, but actually I'm going to throw this to you because we haven't touched on this. And one of the things I promised that we would talk about is what's next for Language Matters. Now, I know that you're finishing up at Diabetes Australia, so you can make the biggest, claims and wish lists that you want right now, and I won't hold you accountable. So tell us what is next for the Language Matters movement. Where in 10 years' time, when I'm annoying you still somehow and saying, hey, look what's going on now, what would you like to see is happening in the world of language and diabetes?
Well, big question. I think picking up on some of those themes discussed, I'd like to think that and hope that in 10 years' time that we do have a systematic process to be transparent and to be feeding back to people about how people think. I mean, the powerful messages in this discussion are people with diabetes remember the discussion when their diabetes was diagnosed. They remember it 20 years later. The clinician probably doesn't remember it 5 seconds later.
Yep.
Let's help them remember. You know, there are ways, there's fantastic technologies now. So there's lots of ways that feedback can be given, and we shouldn't focus and demonize health professionals here. This is to anyone. There's lots of ways in which we can very appropriately feedback to people in a timely way that the language they've used may have done harm and may not have been ideal and could be changed. And if we can systematize that in the health system and in other places, and if we can train the media, through our efforts to drive the narrative in the mass media in a more useful way. We'll never control social media, of course, but there are ways in which that can be done. So I would hope that systematizing some of this feedback loops around and getting it more embedded into the training and expectations and practices and behaviours of a broad sweep of health professionals would be very good outcomes in 10 years' time.
Wonderful. Thank you. Thank you all so much. It's been absolutely wonderful speaking with all of you and hearing your passion and your enthusiasm and your commitment to this really, really important issue. We would have loved to have had some people from the US and from Canada join us, but somebody draws the short straw, and it is the middle of the night there, and I didn't think it would be all that fair for me to say, please wake up at 3:30 to do this. However, we have some video messages, and we're going to show a video about language that was made in the US by Deb Greenwood. So we've got Deb Greenwood, who's a diabetes educator in the US, has got a little message for us, and then her video. And then we have Seema Nagpal from Diabetes Canada, who is also going to say something. So let me just share my screen and play that, and then I will come back at the end and just say farewell. So let's see if this is going to work. If I share my screen, there we go. Lovely. There's Deb.
Hello, everyone. My name is Deb Greenwood. I'm a nurse and a diabetes care and education specialist from California in the United States. And I want to first congratulate Diabetes Australia for being the leaders that they are and celebrating 10 years of raising awareness that language matters in diabetes care and education. I also want to thank you for the invitation to introduce our award-winning video, Changing the Conversation. I'm so proud of this video because of the way it was co-designed with both people with diabetes and clinicians. We started with the United States paper published by Jane Dickinson and colleagues, published jointly by ADCES and ADA, the use of language in diabetes care and education. And we used the concepts presented in the paper to generate our questions and talking points, and then sent those questions to people with diabetes and clinicians so we could get their answers and feedback. And from that, we crafted the script for the video, which we then finally shared again before filming. And everyone you see in this video are volunteers. They're the clinicians or people with diabetes or those affected by diabetes. And everyone volunteered their time so this video could be freely and widely shared. We're excited to say that the video won both gold and silver Telly Awards and has been shown around the world at diabetes conferences, at corporate meetings, and locally. We're excited it's going to be shared today during this important celebration. And while the Language Matters movement is 10 years old, we do still have more work to do. So we hope you enjoy this empowering video and continue to share it with others.
Words are powerful.
They create reality.
Words can empower.
Or words can blame,
Shame.
Or judge.
So the language we use in healthcare matters.
I am a person with diabetes.
Diabetes doctor.
Diabetes educator.
I'm a person with diabetes, and language matters to me.
Use your voice to raise awareness about the language we use when talking with and about people with diabetes.
It's hard work managing a chronic condition.
It's 24 hours a day, 7 days a week, with no vacation.
With no vacation.
Some words we use in healthcare can make living with diabetes much harder.
Words like sufferer,
Non-compliant.
Diabetic, non-adherent,
Brittle or uncontrolled.
and words that imply that you should do better.
Or work harder, as if they're not doing their best.
And words can make people feel
judged, frustrated, anxious, labeled,
Oversimplified. Dismissed.
Disrespected,
Misunderstood. Embarrassed.
discouraged,
Accused. Guilty.
blamed,
Shamed.
that is my fault that I have diabetes,
That I'm lazy.
that I don't care.
Like I have a character flaw.
or that I failed.
It's time to change the conversation. We can use words that are neutral and non-judgmental.
We can use words that are based on facts, action, and biology.
Words that are free from stigma, shame, or blame. Words that do not judge. When we raise our voices together,
we can change the way people feel. I'll feel respected, cared about, valued, not judged, understood, listened to, treated as an equal.
they'll feel that they're important,
that they are included in the conversation.
That they're not just an illness or a disease.
but simply a person.
And when we change the way people feel,
We can make diabetes easier to manage.
First and foremost, I'm a man,
Wife,
Father,
I'm a son.
friend,
professional.
person.
and I just happen to live with diabetes.
I live well with diabetes.
I can do anything I want to do. So let's raise our voices.
Together, we can make a difference.
Let the world know language is important to you.
Because words are powerful.
And language
And language matters.
Hello from Ottawa, Ontario, Canada. My name is Dr. Seema Nagpal, and I am Vice President of Science and Policy with Diabetes Canada. I am very pleased to be joining you from the traditional land of the Algonquin and Anishinaabe Nations. Thank you for the invitation to speak with you today and to let you know about our interest in changing the language used about both people living with diabetes and the illness itself. Until May of 2020, Diabetes Canada had no formal position to encourage and promote appropriate language about diabetes. At that time, a consensus statement was developed by a working group comprised of healthcare professionals and patient partners. We collaborated with healthcare professionals from Diabetes Canada and Diabetes Action Canada's patient circles. Diabetes Action Canada is a network that is funded nationally through the Strategy for Patient-Oriented Research. We had an excellent opportunity to work together and to develop the principles outlined in this document. We have been using it since that time in our own Diabetes Canada communications and mission work, advancing these principles when we're working with partnering organizations, thereby increasing public awareness about diabetes and the reduction of stigma, and by promoting it to healthcare providers. So this improvement in language can enhance the health, wellness, and self-efficacy of people living with diabetes. These are no small undertakings, but we believe that with persistence and over time, we will be able to change the language to one that is able to support a person living with diabetes and their best possible outcomes. Thank you again for your interest and have a great event.
Well, that's fantastic. So thank you to Deb and to Seema as well for sending those. Thank you once again to our panel. If you want to turn your cameras back on, you can. And thank you very, very much for joining us. Thank you to everybody watching. I know that we did have some questions. This video will be available on our Facebook page forevermore. So please, you can watch it again. You can share it. We will also pop it on our YouTube channel. We've got to get the message out. We need to keep talking language. 10 years is a pretty good effort, but I still feel that this is, you know, we're just starting. So there's lots more to go. So thank you very much to everybody. And I'm sorry that we've gone over a little bit, but thank you. And we can end the broadcast now. Thank you very much.
Thanks, Renzo.
Bye.